Last week, we talked about the role of insulin in fixing DKA, and one of the things that we mentioned was that you don't have to give a bolus prior to the infusion, and in fact, the data tells us that the bolus doesn't fix the DKA faster, doesn't close the gap faster, doesn't fix the pH faster, but it does result in more episodes of hypoglycemia and hypokalemia. There are those situations where I will give a bolus despite that evidence. There are two big ones that come to mind. The first is when there's a delay in getting your insulin drip from the pharmacy. There are lots of places out there, I've worked in some of these places, where you put the order in and it takes 30 to 45 minutes to actually get your insulin infusion to the bedside. In those situations, I'm going to give the bolus to get some insulin into the patient's system and to start to fix the underlying pathology. The second place where I'm going to give a bolus is in patients who have severe acidosis. If the bicarb is in the single digits, I'm going to strongly consider giving a bolus so that I can get to therapeutic insulin levels faster and start to fix that acidosis by turning off the ketogenesis. If you're going to bolus, the dose is 0.1 units per kilo, and while most of the time we don't need to give the bolus, there are a couple of situations where we should consider it.